Good morning or good afternoon to you, wherever you may be joining us from. We are excited to meet together today. So, my name is Yvonne Alsop, and I'd like to welcome you to our webinar, co-sponsored by the two sections from APHA, School Health and Wellness, and the Public Health Education Health Promotion sections. I am the Professional Development Chair for the APHA section of School Health and Wellness, excuse me, and will serve as our moderator. It's my pleasure to welcome you to National Public Health Week as well, with the theme of Ready, Set, Action. And as we celebrate, we want to take a moment to recognize how public health has improved our daily lives, safeguarded our families, expanded our lifespans, and strengthened our communities. This week, it's also a chance to honor the public health workers who show up for us every day and to advocate for policies and practices that promote good health for all. So, thank you and welcome. Additionally, this year for National Public Health Week, with the theme of Ready, Set, Action, we just wanted to focus on what we're doing for our webinar today, which is to invite you to check out all of the things that are being done, but then also think about what you can do within your own sphere. So that part of that is participating in things like our webinar, and we just want to remind you, all of our guests, that you will be able to get credit for this if necessary, or if you want. You can get a CHES or MCHES or CPH Category 2 credits for that. And we also encourage you to utilize the chat function. We'll be keeping record of questions and those who are here. So please, if you have questions throughout, put those in the chat. And as we get started, I want to share with you some of our notes and about things coming up. So for PHEHP and some of their National Public Health Week events, we encourage you to seek out their LinkedIn page. They have a lot more information on some of the webinars they are putting out. Looks like they've got some that are really great coming up throughout the rest of this week. So we encourage you to check those out. Wednesday, Thursday, Friday, you can see here on the screen, and those look really engaging to me. So if you can, please, we encourage you to get involved there and meet with them. And then we also encourage you as well to reach out to us from School Health and Wellness. We have a newsletter coming out, and we want to hear the good news from you. The things that you're doing and engaging with. This could be resources for us as well, or journal publications, or how your school, community, or campus, or organization are celebrating National Public Health Week. This could even include awards and accolades, or maybe grants that you've been able to receive, advocacy tips as well, and just successful collaborations. We want to collaborate. There's so many involved in school health and wellness. So please reach out to us. And we encourage you to be part of our newsletter. So our objectives for today's new webinar are multifaceted. We hope that by the end of this webinar, you'll be able to identify at least 3 key steps in planning and implementing mobile clinics to improve healthcare access and outcomes for children, adolescents, and young adults in rural communities. And we also hope that you'll be able to describe how strong collaborations between medical mobile clinics and school districts improve healthcare delivery, reduce logistical barriers, and advance health equity for students, families, and staff in rural communities. With that, I would like to introduce you to our guest speakers for today, Dr. Kelly Wilson from Texas A&M, and then also Alejandro Espinosa from Desert Healthcare District and Foundation. So I will go ahead and share with you some information about them. Our first speaker is going to be Dr. Kelly Wilson. She's a professor at Texas A&M University, College Station, and a nationally recognized scholar in adolescent and school health. For more than 2 decades, her work is focused on strengthening school and community systems that support student health, well-being, and academic success. Her research focuses on adolescent health, school health systems, and rural health equity to improve access to care, mental health literacy, and preventive services for students and families. Her research integrates community partnerships, implementation science, and systems thinking to support schools as key partners in advancing student health, well-being, and academic success. And then our second guest speaker is Alejandro Espinosa. He's the Chief of Community Engagement at Desert Healthcare District and Foundation in Palm Springs, California. His work has been especially impactful in farm working communities, partnering with local organizations, clinics, and trusted leaders to provide culturally responsive services and health education to workers and their families. Prior to his work at Desert Healthcare District, Alejandro served as Program Director of Chronic Diseases and Special Projects at Latino Health Access in Santa Ana, California. In addition to his field leadership, Alejandro serves as faculty in the public health program at California State University, Fullerton, where he educates and mentors emerging public health professionals. He brings a practice-based lens to his teachings, emphasizing community engagement, cultural humility, and real-world impact. And we are excited to have both of them here with us today. We will first hear from Dr. Wilson, followed by Mr. Espinosa. So we will turn the time over to Dr. Wilson. Thank you for joining us. You are muted, Dr. Wilson.
Thank you for that heads up. I was trying to be respectful of keeping things quiet until it was my turn to talk. But thank you for the introduction. And it's really exciting to be here with everyone today, celebrating Public Health Week, but also presenting some work that is happening in two large states, but in really rural, small communities oftentimes. So I'm definitely sharing the Texas perspective, and I look forward to hearing more from California. But really, what I'm excited about is talking about the intersection between not only rural health, but also the school system and how we bring the school system into health services and the educational entity. And then we're also really excited to bring in workforce development into our mobile clinics. And so really looking at the idea of we're not just building a mobile clinic, but we're looking at a coordinated way to think about access and think about workforce development and the health of communities. And so we know that when we go into rural communities, especially with a unit like a mobile clinic, we have branding on our mobile clinic that says Texas A&M University, but really we have the heart of people and service providers, youth providers who are influencing child and adolescent health. So we know that Rural Healthy People identifies healthcare access as an issue for young people living in rural communities, and accessing care is so important to them. And we appreciate being able to work with our communities and provide these services. So I definitely want to acknowledge Dr. Nicole Kroll, who is the clinic coordinator and the PI over our mobile clinics. And then also the mobile clinic team, which are the people who get to spend every day in our rural communities and with young people. So today we are going to be talking about three major things. Number one, how we have coordinated our model of care and how the workflow is integrated into providing services in multiple communities and multiple counties in Texas. We're also going to share a little bit about our view on how we're reducing barriers to healthcare, not only for residents of rural communities, but also young people, and then also how this is advancing equity. And so really embracing our ability as public health professionals and health service providers to focus on equitable care and coordination in communities overall. And this is a little picture or a picture of one of our mobile clinics. We actually have two that serve the Brazos Valley. And I do not have a map, but I do wish that I had put a map into my presentation. But this mobile coach actually the two mobile coaches go into HRSA designated rural communities. So they have met those designated markers for being rural. And we drive out from our hub, which is Bryan College Station, to these locations. So 5 days a week, the goal is to drive the clinic, drive the staff to locations that are up to 2 hours away. And so this coach, you could see a picture of the clinic that is in there. We will be talking a little bit more about the different kinds of services that are provided, but this is a vision of what we are working with. And so when we think about rural health access and what this mobile coach and mobile clinic is doing, is really thinking about provider shortages. So with myself being a professor in the College of Nursing, one of the things we pride ourselves on is that we do have a nurse-led mobile clinic. And we do have medical oversight. It's required in the state of Texas. We have medical oversight that is provided in partnership with faculty in our College of Medicine. But like I mentioned, we have a collaborative approach that includes not only our nurse practitioner, which is lead of the clinic, we also have an RN that is regularly on the clinic. We have a community health worker who also helps with paperwork. And so addressing provider shortages in multiple ways and really bringing providers to the rural communities. Many of us that are on this call do know that transportation in rural communities is difficult. I know that with urban communities, transportation is difficult as well. But given the isolation of the amount of time that it takes for residents of rural communities to get to healthcare providers, this leaves parents in the school setting having to take time off of work and also really thinking about absences from school for the young people themselves. So we're decreasing the transportation barriers by having these mobile coaches go into the communities. And the other unique thing is our partnership with the schools and the school districts is that the mobile coach actually resides either in the parking lot of a school or in an adjacent parking lot to the school. So we do have a revolving door with young people who are students, and then also we're serving the community and their parents by having that close proximity to school where they are going on a regular basis. And then we're addressing limited services. So in addition to the primary care services that are provided on a regular basis. We will also have special initiatives that include vaccination clinics. Those are extremely popular as we approach the start of a school year. And then we have ideal times that we also schedule additional immunization clinics or vaccine clinics. We partner with our dental school to have a dental health week that we're not only providing the primary care services, but we also have dental weeks with oral health being a focus. And then also another popular time for our mobile clinic services is when students are due for their sport physicals. And so we're increasing access to services from the school health perspective. As a slight sidebar, we also have a CPRIT clinic, which is focused on cancer screening, mostly women's health. So that is not necessarily the focus from the school perspective, but again, addressing these rural health shortages overall. And so our coordinated model is something that is very important from our perspective. Like I've already mentioned, we're partnering from the university academic perspective. As the College of Nursing, we're partnering with our College of Medicine, our dental school, our School of Public Health is a critical partner, where we're partnering the mobile clinic with schools, and that is a priority. Dr. Kroll gets several calls about, well, can you bring the mobile clinic out and do this health fair? And she does prioritize the clinic and the services over having a presence at a health fair or other events. And another critical piece, because we have the coach going to multiple rural counties, is our telehealth integration. So we have telehealth services that are provided out of the coach, but also provided out of home base in Bryan College Station. So that way we have the continuous care, and our mobile coach can be that home, even if people are dialing in or calling in for their services, that they will always have access to. And so really just to emphasize that continuity of care and the importance of our mobile clinic being a medical home, especially for young people who are in the schools, and definitely keeping their families and the greater community in mind when we're thinking about this coordinated, connected approach. So the next slide is just a little bit of a picture. I wanted to make sure that I didn't have just words on slides, but some real pictures that were taken out in the communities to show part of our nurse-led model, and really recognizing what matters is getting out in the community and working with our populations and working with our teams. So that way we're viewed as being responsive and really focusing on relationship building, so that we know that we have accessible and trusted healthcare, and that we are a go-to for our community members who may be struggling with care because they don't have providers in their community. And so for this presentation, because it is that great partnership between PHEHP and the School Health Wellness section, I wanted to make sure that I mentioned our WISC alignment and those components that really nicely align between WISC and our mobile coach, and the view in which the services are provided. So we have the health services that are a nurse practitioner led. And then we also have the community engagement piece, which you just saw those snapshots of really integrating in. And this allows us to not only bring the WISC model to perspective, but also make these items actionable, because our school health partners are so critical in the work that we do. In addition to the mobile coach going out into communities, we also have one of our nurse faculty members who meets regularly with an advisory team that has representation not only with the medical providers, but the other providers who are incorporated in the WISC model, and also our SHAC representatives as well. So those School Health Advisory Council meetings. I wanted to give you a little bit of our impact data, and this is one of the challenges that we have with some folks who are not necessarily focused on the rural perspective and the rural perspective of mobile care. We know that we are reaching communities, and sometimes we have very slow days on the mobile coach and in the clinic overall with seeing 4 patients. But we know that that provides the opportunity to have in-person visits. And then we also have telehealth visits as well, which was already mentioned. But one of the things here with this particular data point is our in-person visits are really critical for that relationship building piece. And this impact data, I should have put it on the slide, was actually from our first year in service. And our mobile coach has been in service for 2 years overall. And so overall, from a patient perspective, the top conditions that we see are hypertension and diabetes. But from the youth perspective, those vaccine clinics are a critical piece, the sport physicals, and then also the dental and oral health visits are very important for showing our reach and showing who we are serving. So then the other important component, the other thing is we started 2 years ago with the mobile clinic being launched for services. We have actually received a HRSA grant to fund the purchasing of one mobile clinic. And then we have a foundation grant that purchased the other mobile clinic. But especially for our HRSA grant, in addition to providing services for the students, the student patients, we are also serving our Texas A&M students in workforce development. And so with our student training, our students are not only getting receiving some of their clinical time, but they are also being exposed to other professions. So at any given moment, we may have interns or volunteers from public health, from nursing, from medicine, and from behavioral health, where they're able to look at that integrated perspective of services and really be able to talk with their student peers from what their profession is doing and how they're being prepared. And then we also are focused on building the rural pipeline. So recognizing what are some of these challenges and barriers that are present for rural communities and identifying rural serving professionals who can be exposed and recognize that just because we have a slow clinic day doesn't mean that we're not impacting the patients or the communities. So while we know that this isolation and this desert of care is a barrier, it's also meaningful and impactful work, is the overarching message that we provide to those students who are in training. And as you'll also hear from from Alejandro when he presents, there's a lot of challenges that come not only with I think students' healthcare services, but also with mobile clinics. And serving rural communities, we do run into administrative barriers. Despite being in a university setting, we still have a lot of discussions around return on investment and recognizing that what happens when the coach may not be able to go out and serve the communities because it has to go in for an oil change. Or what happens when there's a little fender bender with the mobile coach and it can't go out because it has to go into the shop. So we have administrative barriers from that financial perspective and what will happen when we no longer have HRSA funding or foundation funding. We also have some of those mechanical kind of barriers, and then also just community buy-in and community support, and really being able to advocate for the need for these services in the rural communities. And I've kind of mentioned the funding gaps. And so that is a big question for us, especially as we look at funding opportunities for health services and public health coming from a government perspective. How do we lean on either our infrastructure from the university or state perspective, while recognizing any financial barriers that our patients and individuals living in rural communities might have overall is definitely an ongoing challenge for our organization. And so this really, from the practical perspective, so that both from the evaluation perspective, the collaborating with some of our partners, and then also building the capacity of our service providers, we're always thinking about the implications. So we know that we have these barriers. We know that they are similar barriers that exist either from the rural health perspective and or the mobile care perspective. And so we're thinking about what are our implications and how do we overcome these challenges. And so we are really focused on partnering with our Telehealth Institute and our Institute for Healthcare Access in how can we invest in hybrid care? So how can we invest in increasing telehealth services? How can we invest in mobile clinics that might be unique in perspective? If you look at some of the initiatives that are happening at Texas A&M University, we not only have the mobile coach, which is that clinic on wheels, but we are also working with other innovative modalities that look very different than brick and mortar clinics as rural health clinics have traditionally seen. And then in alignment with the administrative barriers, we also have this policy that really comes into play. And I think right now we are all in the public health field and really being challenged with different policies and support that might be happening within federal structures or within state structures, and ensuring that the services that we are providing is aligned with legislation and aligned with where our elected officials are investing and where our government sources are investing overall. So we all really focus on how do we become advocates for these services and reaching our young people in communities overall. And so that brings us to one of the key takeaways, and really focusing on our mobile clinics are an opportunity to focus on equity and equitable approaches to healthcare in rural communities, and also bringing forward that health literacy and that healthcare resilience that is often faced in rural communities. So we, as the youth serving professionals and the public serving professionals, will continue to focus on accessibility and how we can make our healthcare as consistent and connected as possible, continuing to build those relationships with the schools, school administrators, and even those that are not in that health profession, but recognizing the partnership and how it can help those school outcomes and help young people be successful from an educational perspective and their health perspective. And this coordinated care model really is a feedback loop where I know that I've already mentioned this and said this, but where we value the role of schools and how important the school district is and school administration is, along with the school nurses and the students. So having them recognize us as a medical home. And then we have our mobile clinic and the importance of our nurse-led care and our workforce development, really encouraging future nurses and other future health professionals to embrace rural communities as a setting for healthcare overall, and then utilizing our telehealth partnerships for continuity and behavioral health, and integrating that all together. So To wrap this up, this is our mobile clinics are an investment in hybrid care models and combining not only the mobile health model, but also telehealth, strengthening the school health partnerships from an administrative perspective and a youth perspective. I've already mentioned the nurse-led scope of care, and then really thinking about our workflow and our operations as best practice and informing other models of care as mobile clinics continue to reach our rural communities. So with that, I will pass the stage over to our next presenter, and I look forward to hearing about a different community.
Wonderful. Great work, Kelly. This is awesome. This is great. I love to hear different perspectives of, different areas within, the United States and how y'all are, impacting students and not only, serving the students, but also serving as a learning platform for the next wave of providers that are going to be changing the public health landscape. So great job. Great job. Very excited. I'm Alejandro Espinosa, the Chief of Community Engagement for the Desert Healthcare District and Foundation. And I also wanted to give credit to my colleague, Megan Kane, who is a Senior Program Officer, who we co-created the content and the presentation and presented together at APHA. So we're very excited to have this opportunity to present in this platform. Next slide, please. A little bit about who we are. We're the Desert Healthcare District. We established in 1948 as a special district out here in the Palm Springs area, the Coachella Valley. Our mission is to achieve optimal health at all stages of life for all district residents, and our vision is to equitably connect Coachella Valley residents to health and wellness services and programs through philanthropy, health facilities, information, and community education and public policy. We try to do a lot. We own a hospital here, which is Desert Regional Medical Center, but we work on the foundation side, and we serve primarily as a philanthropic organization, and also have some internal programming, which is our mobile health initiative, which I'll be speaking about today. So, next slide, please. So here, just a geographic representation of who we serve. We serve roughly 450,000 residents over a 457 square mile area. If you've been out to our area here in Palm Springs, you think of Palm Springs about the wonderful resorts and golf courses and spas. And now, as of, I would say, the last 15 years or so, we're the host to the Coachella Fest, which we have here in the next couple of years. Next couple of weeks, we'll be hosting, hundreds of, or thousands, I should say, of music lovers here in our own backyard. But for us, the landscape's a little bit different from the Palm Springs vision that everybody thinks of the Coachella Valley. We do have some really challenged areas, underserved areas throughout the Coachella Valley, even within Palm Springs. But as we start moving a little bit closer there to the Salton Sea, we started dealing with a lot of farm worker rural communities that have very, very special needs. Healthcare access for them is driving 35 minutes, 40 minutes to the nearest health facility in case of an emergency. So for us to be able to develop this mobile healthcare initiative is addressing one of those needs. Next slide, please. So just a little bit overview of my presentation. We'll talk a little bit about the history and evolution of our mobile health initiative, also some challenges, logistics and operations of how do we actually deploy our mobile units, some of the strategic partnerships that we have developed along the way, some of the logistics and operations, community impact and future growth, and our conclusion. Next slide, please. And next slide. So for us, at the Desert Healthcare District, we started our mobile unit initiative during COVID. During COVID, we saw a huge need for organizations and communities that needed access to the COVID-19 vaccine and testing at that time. This is the time when the COVID vaccine and testing materials were very, very scarce. Here in California, we had to do a online registration to get a COVID vaccine. And for some of these communities, especially our agricultural communities or farm workers, it was very tough for them to actually, do that process. So we try to facilitate that. We had a group of doctors from DPMG Health, who is a local physician group here who operates our mobile units, and they started coming out with us. We had a group of community health workers that were breaking down barriers, overcoming transportation, healthcare access, and other challenges that came across the way. Some of the community members, when they were trying to enroll on that online system, it was too complicated for them. Some of them were not really tech savvy. And though that presented a whole slew of new challenges. So for us to actually go out into the community, help them with the registration, employ community health workers to assist in some of the outreach, enrollment, and registration really, really kind of laid a really good foundation for our mobile health initiative. Next slide, please. Next slide. So here locally, in the Coachella Valley, there's a huge need for healthcare services. We are a medically underserved area. We commissioned a report in 2023 by Huron Consultant that highlighted the need for an additional 71 pediatricians by 2027, next year, to meet the demand, underscoring a critical gap in care. Some of the barriers that we face here locally in the delay of care is long wait times for pediatric appointments. They are waiting 2 or 3 months. Our community members, when we encounter, some of the parents out at these mobile clinics, they tell us that they have to wait 2 or 3 months even to schedule an appointment with their pediatrician. There's also, lack of available pediatricians here locally. Transportation issues, as I mentioned earlier, somebody from the east end of the Coachella Valley to even get remotely close to a medical provider, they have to drive anywhere between 30 minutes to 35 minutes just to even get to their nearest healthcare facility. And then scheduling conflicts, either hours and days of operation for farm worker families and other low-income families that work two jobs, for them to get out of work and make the 9 a.m. to 5 p.m. Traditional clinic schedule makes it really tough for them. And also the days of operation. We have very few clinics here locally that are open on Saturdays. And even those that are open on Saturdays, their wait times we're looking into a couple of months out just to even get an appointment for their children. So that is the challenge that we were faced when we started thinking about going into the schools and providing healthcare through our mobile units. And we started addressing this with some partnerships that I will discuss here in the next slide. So for us, we established a partnership. First of all, we needed the mobile unit, so we invested a little bit under $500,000 to purchase and do the maintenance of one medical mobile unit, along with an additional trainer and a clinic and pharmacy hub. The purchase was supported by two grants totaling $315,000 from another special district here, which is the Coachella Valley Resource Conservation District. In order for us to, provide services and actually have access for the Vaccines for Children program, we knew that we needed to establish a pharmacy hub. So then our medical partner, DPMG Health, was able to enroll in the Vaccines for Children program and for us to have low cost access to vaccines. With the medical partnership, we awarded over $1.5 million over the next 3 years via an RFP process to DPMG Health for operations, staffing, and patient care. And some of the folks that we have, as the providers that we have on our mobile units, are licensed physicians, medical assistants, nurse practitioners, psychiatrists, and pharmacists. So we are not only able to treat the patient, prescribe a medication, but we're also able to provide medication on site. So we carry the 100 most prescribed medications on our mobile unit that we're able to dispense right then and there, because we know if we give a prescription to a family, chances are they're going to be facing the same barriers as their access to care. So we try to reduce that barrier by having this pharmacy hub, having the medication in our mobile unit so that we could prescribe and also dispense at the same time. And then us internally, At the Desert Healthcare District, we do provide some staffing and support. We have three dedicated staff members, which includes myself, our program assistant, and our program support specialist. And we provide all of the logistical support. We do the outreach. We do all the MOUs with the hosting sites. We set up the scheduling. We do the marketing, the outreach to the communities to ensure that the doctors, I always like to tell them that I want them to do what they do best, and that is medicine. I don't need them to do the marketing. I don't need them to do the outreach. I want them just to show up and have a full schedule of patients ready for them to be seen by the medical provider. So that's how we established a partnership between us at the Desert Healthcare District and our wonderful partners at DPMG Health, who operate our two mobile units and operate the clinic and the pharmacy hub. Next slide, please. So, as part of our partnerships, we started the school-based vaccination clinics initiative. Next slide. During COVID. So, during COVID, it provided us a great opportunity for us to actually partner with our three local school districts, where we were able to provide information, regarding COVID and the resources for us to actually bring some of these vaccination clinics and testing during school hours. We even entered into MOU where we had the parents be able to sign the parental consent form for us to vaccinate the children without the parent being present, which was a total game changer for us and obviously reduced many barriers for the parents. But as part of our school-based vaccination clinics, next slide, please. We try to make it fun. We try to make it a fun and welcoming environment. These clinics differed a little bit from the adult clinics. They featured a superhero theme and age-appropriate educational materials. So one of our subcontractors developed this uh, a comic book character called Captain Empath, and then the villain COVID-19. As you can see there, they had little costumes and they would play out a skit during school hours, and the kids really really loved that, and it just kind of gave them an opportunity to see in very age appropriate presentation the impact and the need for them to do the social distancing, wearing their mask, washing their hands, etc. So it was really, really nice for us to kind of develop these fun activities for the students to ensure that, something that's really scary at that time was softened a little bit and they were able to, learn about COVID-19 and the potential impact that they could have on themselves and their family members. So that's how we started the partnership with the three local school districts. Next slide, please. So a little bit of the logistics and operations that we do. Um, so we do a lot of partnership and planning. So we establish all the MOUs with the school districts. We provide the liability insurance, coordinate the clinic requests based on compliance data or identify student needs. So if there's, like Kelly mentioned, if there is the need for vaccines, sports physical, or pediatric consultation, all three school district lead nurses reach out to us directly and say, hey, we need a vaccination clinic. We need a Tdap vaccination clinic for those elementary school age students that are entering middle school. So we schedule some of those. And during the peak of the fall and spring sports seasons, the athletic directors reach out to us directly so we could schedule some of those sports physicals. So we do the site selection and scheduling. And we also have the staffing, resources, and consent. We do all of those forms in partnership with the school district to ensure that the parents know exactly what their students are going to be receiving and for them to authorize to receive some of those services. And then during the actual leading up to the clinic date, we do a lot of outreach and clinic day operations. So we create outreach materials for the school district to distribute via email and the parent portals. On clinic day, the hosting site provides logistical support, and clinic staff deliver services and nurses documenting them into the health record system. So not only do we have our staff there, we also have school district nurses that are entering all of this information, especially on the vaccines side of our services into the healthcare record system. So the child goes from non-compliant to compliant, and they're able to continue to attend school. And then also we do identify some additional needs that some of these students or their families may have. So we do some referrals and follow up for them. We do also have the brick and mortar hub So then any family that needs to be seen or provided services that are not able to be done within the mobile unit, we do refer them to the brick and mortar. So we could do that extensive, those extensive services that we're not able to provide in the mobile unit. So that's how we operate the mobile units. And some of the impact that we've had, tremendous outcomes since we started. So during our school-based clinics, when we started, and I believe it was May of 2023, we've across 75 clinic days, we have served 4,249 youth. The majority of the clinics have focused on two high demand needs. The majority of them being vaccination clinics, and 22 clinics or 30% of them were sports physicals. As you can see there, we have the peak and valleys. Those and the sports physicals are normally typically when we have either fall sports or spring sports, and the athletic directors reach out to us and we're able to provide the sports physicals. And we're able to do the sports physicals, once again, during school hours. Some of the booster clubs actually do a fundraising out of these sports physicals, and they're able to raise significant amount of um, resources for their athletic department. Next slide, please. And then throughout the clinics that we've done, so we've served 4,511 youth. We have reached 32 schools in our local region. We have deployed the mobile unit 81 times. And once again, the top clinic type that we do are vaccination clinics. Next slide, please. And then some of the community impact that we've seen through the deployment of our mobile units, it's first and foremost is the student health and well-being. We provide them timely access to vaccines, physicals, and preventative cares. Obviously, we reduce illness and absenteeism, which the school districts love every time we come out and treat, some of their students, and improve overall physical and mental health of the students. Also, the community, family and community support. We have fewer missed work days for parents, so they don't have to take a day off to actually take their student or their child to the doctor, so they're able to actually provide the services, within the school day and the school hours, so they don't have to take those sick days. So we also reduce transportation and scheduling burdens on the family. And then we also have strengthened connection between families and healthcare providers. So not only are we able to treat the student, but we're also able to provide resources and schedule appointments for the family members as well. And then the education and societal impacts, obviously students stay healthier and more engaged in learning. Program yield measurable societal benefits, and then promotes equity and healthcare access across communities by bringing these mobile units out into the community. Next slide. So for us, we do have some plans. We do have a couple of meetings coming up with our school districts. We're thinking about doing rotating weekly clinics, just as Kelly mentioned. That's very exciting to see that model already being implemented. To be able to have a mobile unit rotate across different schools to give these students and their families a point of access somewhere within, the school district. So that's very exciting. We're also looking into behavioral health expansion to be able to provide behavioral health services to the students. And one of the newest things that we've done is doing vision clinics. We have subcontracted out with a vision clinic provider that does eye screenings and provides glasses for the children. And we're contemplating, and right now we're working with a couple of manufacturers to actually build our own vision clinic to be able to provide eye screening and glasses for students here within all three school districts. So we're very excited. We've launched that. Launched a couple of events with our vision partner, and within 1 hour of us releasing the flyer for 65 appointments, all 65 appointments were booked within 45 minutes. It's just the need is so tremendous out there. Even students that have glasses and that are insured, they have broken glasses that, they have to wait for their insurance benefits to renew a year or two from the point when they receive them. So they're, dealing with glasses that are no longer serviceable. And for us to come in into the school and provide those new glasses for them is a game changer. Obviously, they're able to, to read a little bit better, to understand the material, and to be able to increase their academic performance. So we're very excited that potentially we'll be having our own vision mobile unit here in the next 3 to 6 months. So we're very excited about that. And that's all that I have, I think, on our presentation. So thank you once again for the opportunity to present some of the work that we're doing out here in the desert in California. So looking forward to some of the questions and continuing the conversation with everybody here.
Thank you, Kelly and Alejandro, for those great presentations and just informing us more about some of the good work that you are doing. One of the questions that I have that came in, which I think, both of you could provide some light on this, is how do you decide which school or school system to visit at any one time? Who gets a visit from the mobile clinic?
And I'll go ahead and start my response since Alejandro said that they're working on their weekly schedule. So we basically set the schedule for a 9-month time period. So we'll decide school districts at the start of a school year, and we're basically committed for the next 9 months. And a lot of deciding what day we go to the school or the school district is in collaboration with administration, the school nurses, and community conversations to determine that it is the best day. But we have kept a consistent schedule for Monday, Tuesday, Wednesday, Thursday, and Friday. Meaning on Monday, we are going out. I'll use my Wilson ISD. On Monday, we're going out to Wilson ISD, and Monday remains that day. That way, that is part of our continuity plan. That if people really wanted face-to-face walk-in kind of services, they know that Monday is their day or Thursday is their day. And then the other thing that we do have is we have certain days that flip, meaning we have two very, very small rural communities that it's a biweekly schedule. So it's every other week we're in city A, and then the other week we're in city B. So we're making decisions, in advance so that a calendar can be posted. Community members know when we're going to be out there. We're making the decisions with community members. And then we're keeping that consistency. And then in the background, we're talking about any pivots or any changes that might need to happen for the next year.
Mhm.
Great.
And on our end, we are in conversation on a weekly basis with the lead nurses at all three school districts, and they run reports on, the compliance, the vaccine compliance of their students, and then they reach out when they reach a certain threshold to say, "Hey, Alejandro, we would like to schedule a Tdap vaccination clinic, or we have a transitional kindergarten or kindergarten enrollment clinic where those students will need vaccines." So then we set up those vaccination clinics. So for us, we are working on that weekly schedule, but on us is pretty much when the nurses reach out to us and they feel that there is a need. We try to schedule the clinics a couple of weeks in advance to give families enough time to complete the paperwork, accommodate the schedules if they're willing to come in with their child for the service. So, and then the school district has time also to release some of that information doing the parent portals, emails, etc. So that's how we're traditionally scheduling our vaccination clinics.
Thank you. So there's a question that just came in, I think, in follow-up to that, looking at scheduling and relating to publicizing outreach. So how do you go about with, scheduling and publicizing outreach to create excitement and awareness for the services the clinics are providing?
On our end, we try to make them fun, and have a fun environment. And sometimes we do have incentives, either a raffle or when it's back to school days, we do provide backpacks with school supplies to kind of create some of that excitement for the students. So for us, we try to make it a fun and welcoming environment for the students. And like I said, sometimes we do have some incentives via raffles or backpack during back to school nights.
And for us, we have some of our health education and health promotion initiatives incorporate some of that fun and giveaways. So we have an oral health simulation. It's a game-based opportunity that the kids can play this game about oral health, and then they receive a little, basically like the little packet that you get after you go to the dentist, which is a toothbrush, a toothpaste, floss. So that is another opportunity to have incentives where it's still linked to their health. Or the other thing that I can think of is in our rural communities, parades are very popular. And so on the weekends, we're not necessarily providing services, but we may have a presence when a parade is happening or a community fair. And so really getting word out through those community events where community members are present.
Involvement in the communities. That's key, right? You're getting that buy-in with those fun incentives and then also being part of the community as well. So just to end in these last few minutes, I know both of you touched on some of the numbers and some of the impact that you've had, but maybe you could elaborate a little bit on how many you can accommodate at one time when providing services, and then satisfaction. What have been the satisfaction rates with clinic patients and with school personnel and with the communities? If you could both elaborate on those two things, and then I think we'll wrap up after that.
Yeah, so on our end, depending on for the sports physicals, I think the most students that we've seen in a sports physical clinic, I think was 250 during a 5 hour period. So we set up the whole gymnasium with different stations, and we have upwards of, I think it was 15 to 18 providers that are doing all of the different stations. And with the vaccination clinics, we get a roster of those students when we show up to a school site, so we know exactly the quantity of vaccines that we need to take, the appropriate amount of personnel. I think the most that we've done in a 4 hour period with Tdap, I believe, was 210, I think it was, students. So we're a wild oil machine from the registration, the check-in, the waiting area, and some of those fun activities that we have. We have coloring books, we have all that, so the students are not so antsy when they're sitting there waiting for their vaccine. So for us, it's really just trying to accommodate the large numbers, and we get that information prior to showing up to a clinic.
Yeah, and I'll say that we are also have some large events that don't happen within the clinic itself. So any of the large events, similar to what Alejandro is saying, we have to get approval from our compliance officer in order to be able to go provide those services. So our coach itself only has two clinic exam rooms, which is very limited. And so knowing that when we do have large events, we go through compliance. We know that we have limited time in the coach or in the clinic with patients one-on-one, but that's also where we partner with our telehealth. And there's a question about how we relate telehealth services. And essentially we'll do referrals to ourselves in some ways because we have like a psych NP that provides telehealth services from a behavioral perspective from our college. But we also have an integrated behavioral health model that is very focused on telehealth services overall. So I would say when we're looking at the reach and the patient reach, we're trying to modify and reach as many as possible, despite, like being in communities where patient numbers may be small.
Well, thank you both for sharing, these presentations with us today. They were very great. And I think very enlightening too. Sometimes we think of mobile clinics and we think it's just the coach or just the van that's going and you're serving only one or two individuals at a time. But in reality, mobile clinics are an extension of, healthcare and meeting as many people as we can and their needs and meeting them where they're at. So thank you both. And thank you all for attending our webinar today. We hope you enjoyed it and encourage you to continue to get involved in the National Public Health Week events for both the public health education and health promotion and the school health and wellness section. So thank you all for attending.
Thank you.
Thank you.